You guys do it on a yearly basis? This is done on a yearly basis?
Actually this year we are having the second course, but ideally we will have one thing.
नहीं अभी सुबह 7 बजे पानी ले आओ बंद करो यार पता नहीं क्या
बहुत अच्छे निकलते दाल खाओ टेस्टी बहुत टेस्टी अभी दाल कहाँ रखी हो फेंक दी
They can just attend the course, and the other group.
Yeah, I have. Yeah. Okay. Yeah, now it's fine. Yeah. Okay. Okay. All well with you?
Yes, all well. Thank you for agreeing. Thank you.
Thank you. Thank you for having me there. So, shall I just start or?
Yes.
Okay. So, Viju has given me this topic. Thanks a lot, the organization, Minimal Access Surgery. I think this is the future. So,
पानी लेके आओ बचा है और कॉपी हाँ तो भरो मेरे बार नेस्ले में भर के दो
फेना बहुत ज्यादा बच गया फेना क्यों हो गया
hepatectomy, and especially after major hepatectomy. So one can imagine that a lot of portal flow is diverted, which is going to two lobes and is being suddenly diverted towards one lobe. Or if we are doing a trisectionectomy, then it is about two segments of the liver. So what happens is there is a stretch on the sinusoidal endothelium, and this stretch actually triggers the liver regeneration. Now, how much this stretch in terms of volume and pressure is the nitty-gritties of things, and I think that's the area of research if young guys want to pick up on when this stretch actually becomes injury, and then when stretch actually just remains in terms of regenerating the livers. So there are lots of cells involved into this: hepatocytes, stellate cells, sinusoidal endothelial cell, cholangiocytes also, and corpus cells and smooth muscle cells. So I won't go into details of this, but this is something I thought as a student, for the students to know about. So what happens when you have small functional mass? Then you get a portal hyperperfusion, so there is a shear stress, and then there is a disturbance of microcirculation, which leads to ischemia, hepatocyte damage, and then there is compounding congestion as well, because there is a lot of blood going into the liver, and then if there is a congestion on the segment, then it will compound the ischemia. Then there is a hepatic artery buffer response, which decreases the hepatic arterial flow as well because of the high portal flow. And all this lead to liver dysfunction and failure. That's how the mechanism works. I think it's important to know, because if you're doing major liver resections, then this is the way the pathophysiology of liver dysfunction and failures happen. Now, one would have thought that the basic thing about doing is if you just divert the portal flow, things will just improve. But somehow that doesn't happen. We did this graft inflow modulation, obviously this is in the liver transplant setting, and we didn't see any much changes in terms of graft dysfunction after splenic artery ligation, which indirectly decreases the portal flow as well. So these are good areas to think about if you want to become an academic HPB surgeon. Okay. So then moving on to liver regeneration. So there are some of the basic things is about the more you remove, the more of the liver will regenerate. And so this is some of the data on what are the factors which leads to regeneration in liver. And this is obviously in donors. And there were two important things. One is, which I said, the more you remove, the more will liver will regenerate. But at what volume it fails to regenerate is a difficult question to answer. And then the other thing is even the slight amount of hepatocyte damage. So in this particular paper, even an ALT at a higher level was associated with impaired liver regeneration. So even when you have hepatocyte which are not functioning well, which is reflected by high ALT level, will have an impaired liver regeneration as well. So this is again some of the research things which students want to consider. Okay. Now moving to why we should optimize patient for liver resection, because these are high risk procedure associated with high morbidity. And most of these patients will have some sort of comorbidity. We'll come to this part later on as well. And nowadays we see a lot of liver parenchymal abnormalities. And then many of these patients will have associated jaundice and cholangitis, and then they may have inadequate volume. So if we optimize this patient, then we can improve liver regeneration, reduce post-operative complication, enhance overall outcome, and decrease ICU and hospital stay as well. So this is something you should be knowing. Post-hepatectomy liver failure is what is the crux of thing. Is seen in after 10% of major hepatectomy, and this is the major cause of mortality. 60 to 100% of mortality after hepatectomy. Prediction and prevention, that is the best strategy, because once established after hepatectomy, then it is very difficult to salvage as well. Okay. So again, just coming to, so these are the things which are the major players planning for a major hepatectomy. So it is about quality of liver parenchyma, which is basically dependent on age, steatosis, steatohepatitis, the patient had chemotherapy before, whether they have fibrosis or chronic liver disease, cirrhosis, then obviously about remnant volume. Then it's also about extent of resection. So it's also dependent on how much normal liver is going to come out in a particular case. So the scenarios are different for cholangiocarcinoma, where there's a lot of liver, normal liver comes out, in comparison to large HCC, where a lot of tumor volume is coming out. So you need to be careful that volumetry in those two particular situations are different. And so if you're taking out more than 30% of normal liver, then there is chances of running into problem. Okay. Then cholestasis, cholangitis plays a part. Then degree of portal hypertension. We'll come to all this later on as well. So it's about volume and liver. That is basically ability of liver to regenerate. And then if you can tackle that, then the optimal liver regeneration will happen and you can prevent it. So what are the key patient relatives? Obviously, performance status is an important thing, comorbidity assessment, nutritional status, and then there is a lot of now emphasis on pre-rehabilitation, and this is an important thing that every patient actually can rehabilitate before the operation, then you can improve the outcomes as well. We'll come to this part of the story later on as well. Then there are liver related, which I have already emphasized about liver parenchymal abnormalities, FLR assessment, and preoperative biliary drainage. Okay. So performance status, if you're okay, it is okay to have 1 up to maybe 2, and 0 and 1, but 2 is doubtful. If you can optimize them, then they can actually have resection, but then it is again dependent on basis. If it is 3 and 4, obviously they are not fit for any major liver section, and you should not be offering them. Okay, so it is good to opt as possible beforehand. Age is not a bar in terms of, we've done with liver sections on 74, 75-year-old major liver sections. but obviously it depends on what the comorbidity state is at the time. Then obviously many of these patients are elderly now and will have cardiology and pulmonary, so need to evaluate them very well. They should all have and many of them will have coronary artery disease and may have stents done or may need actually preoperative stenting as well. So the safe period for cardiac intervention before major liver resection is 4 weeks at least, and you don't really need to stop equosporin before the resection. It's not a contraindication, and you can just a couple of days before you can stop and you can restart again depending on how the clotting profile and platelet counts are after the resection. So diabetes is a major thing, because all this patient will have metabolic syndrome, NAFLD and NASH, and will come to the. Okay. Nutritional assessment is important. All patients who are being planned for major resection, we need to have an assessment, and also need to look at the frailty as well in terms of particularly albumin may not be a good indicator, especially in patient with chronic liver disease. And you might actually, because there's a lot of research going on in terms of sarcopenia and looking at the muscle mass and frailty index. Those are things you need to assess before the operation and try and optimize the nutrition as much as possible before. Now, when we come to, in terms of now happening for donors, and this is about actually going reverse in terms of nutritional and lifestyle optimization, because we see so many steatosis and steatohepatitis in donors, and this is some of the things which we did. This was an RCT on lifestyle optimization, and basically what it shows was if you do lifestyle optimization, then there is earlier normalization of bilirubin and earlier normalization of INR as well, and the decreased level of AST, ALT compared to ones who didn't have lifestyle optimization. And also there was greater volume of regeneration, liver regeneration. And this is just the molecular markers of liver regeneration, which were also different between the ones who had lifestyle optimization versus not. And also then the early graft dysfunction rate in the recipient was also lower from the donors who have had lifestyle optimization. So this is I think applicable to all liver sections, because we see so much steatosis nowadays and steatohepatitis as well, that when you see an obese patient or when you suspect that patient has got steatosis, steatohepatitis on imaging and everything, then you should put them on lifestyle optimization in order to improve the outcomes as well. And this is what it is happening. This is now changing spectrum. So this is our HCC data, that we're seeing more patients in their 60s rather than in their 40s for liver resection. And as I said before, they will have lots of comorbidities, so they need optimization before being considered for resections. And again, this is etiology is also changing. So previously we used to see more with hepatitis B induced HCC, but nowadays we see more with MAFLD, and this is what it is important to optimize them. So if you can optimize the liver parenchyma before resection, then the chances of post-hepatectomy liver failure will decrease as well. Okay. So just to go through a case that how liver steatosis, steatohepatitis plays a part. So this is the 38-year-old female with gallbladder cancer and cancer gallbladder neck with hilar block. She had an ERCP stenting, and ICG was 3. Her maximum bilirubin was 21. She had ERCP stenting done. At the time of her resection, the bilirubin was 3. This is her scan, and so this is her volumetry, and we had planned and modified extended right hepatectomy. So left lateral was 34, and then we thought that straight away it will be better to do an extended right hepatectomy because the volume looks good. Okay, for the left lateral segment. So she had an extended right hepatectomy with U&Y. You can see the liver there. So that's the left lateral segment. The volume looks good here. this is the transaction plane there. Okay. So post-operatively, she did develop post-hepatectomy liver failure, grade C. She had sepsis, bilateral pneumonia, prolonged mechanical ventilation, SSI, and wound descents. And finally, she did recover in 20 days. So why I got this case here is a few in terms of, on the background, she has steatohepatitis with portal and perisinusoidal fibrosis. So in spite of having good volume, still in terms of developing post-hepatectomy liver failure. And as I said before, in gallbladder cancer, because a chunk of liver is going to come out. So if you're going to take out a lot of normal liver in this type of patient, then they will struggle post-operatively as well. So this is different from HCCs. Okay. So retrospectively, one would have thought that we should have aimed for a higher volume and maybe optimize her better in order to prevent this problem to happen as well. Okay. So, and again, some of the things maybe we should have biopsied a normal liver. If we have done that, then we would have known about the steatohepatitis and fibrosis, and might be we have actually done the portal vein embolization in our case. Okay. So again, it is important to differentiate between simple steatosis and steatohepatitis. Steatohepatitis, and it is known to be associated with post-hepatectomy liver failure. Even in donors, there have been reports of post-hepatectomy liver failure and death from NASH in donors as well. But the good thing is this can be there's one point, need to differentiate between macrovascular steatosis and microvascular. Microvascular is not harmful, but macrovascular is harmful. So if you do a biopsy, you need to look in what is the percentage and what type of steatosis it is. Okay. Then again, you can optimize them. This is our data from the live donors. So there were about we had 159 who 17% had biopsy performed. 56 were initially rejected based on biopsy taken, and then after reversal, 6 had NASH, which were reversed, and steatosis in 43, which was more than 20%. And we got them into a lifestyle optimization protocol, and the NASH also got reversed. In one patient, there was a fibrosis 1, which was also reversed as well. And this is their post-operative recovery. Obviously, the donors with reversal did had a higher peak bilirubin and INR compared to the non-steatotic donors. And normalization also took a time as well. Okay, so the recipients did same, there was no difference. So basically this, what it all means is, this is not, you don't need to hold back. If you can optimize them, evaluate them, and then see what is the impact of the optimization, and then you can take them for the surgery. Okay. Now, when we come to guidelines for safe liver resection, most of the guidelines actually talk about what is the remnant volume, and liver, they will say 20% of TLV in injured liver, that is steatosis, steatohepatitis, CASH, cholangitis, cholestasis. It is 30% of the total liver volume, and in liver disease like fibrosis and cirrhosis, it's about 40% of total liver volume. So when you have inadequate volumes, then you need optimization. So one of the things about this thing is it's focused on remnant liver volume. Okay, and as we saw in the case which I have shown you before, that it's not just about the volume, but it is also about the function of the liver. And you need to see that if the function is not that good, then maybe you should aim for a higher volume in order to increase the safety of your resections. So when you talk about 20% in normal livers, I won't do 20%, and I won't recommend anybody actually to take on as a 20% remnant volume in normal livers. We never do it in donors. So in live liver donors, ideal is about 35% of total liver volume. Acceptable is 30, and we don't take below 30%. And that is because of the safety. And I thought same principles will apply when you're doing major liver resection for other etiologies as well. 20% is too low. Also, when you're looking at volume, just don't look at the percentage. Okay, it is also to see that how much the actual volume is, mass of the liver. So if somebody, an adult who has got whom you're going to leave behind less than 300 grams of liver, they are going to struggle. So be careful, because if you have smallish liver, like 750, 800 grams of liver, and the remnant is, the percentage wise, it will come, it will come more than 30%. But in terms of actual volume, it will be below 300 grams, and those livers are going to struggle after resection. So just be careful. Just don't see at volume, but also see at what actual gram of liver which is going to be left behind as well. Okay. So again, when we say normal, this is data from our own HCC section. Normal was only found in 9%. Otherwise, most patients have chronic hepatitis. 20%, 27% had cirrhosis, and then many of them actually had fibrosis as well. So this is HCC data in terms of background livers. So you hardly find normal livers nowadays actually, especially in patients who have cancers or other etiologies. Okay. Then again, when we come down to volume, you need to make sure, because you had class on imaging and everything, that you're not going to leave congested segments, because congested and ischemic segments are going to create problems. So when you're calculating volume, you need to make sure that you're not going to leave major part of liver which is going to get congested. So this is actually a photograph from a live liver donation, very early part of our experience, where the anterior sector got congested. And you can see this liver is going to struggle. This is not going to grow properly. So if you're planning, so basically the crux is about middle vein, whether you're going to leave the middle vein or take the middle vein. And then you need to see, if you're going to take the middle vein, then how much is the volume and how much section actually will get congested. So these are important things when you're planning for the operation. Okay. So this is just the various tests which you need to look into in order to assess the liver parenchyma, in terms of liver function test. If they have got steatosis, hepatitis, it can be reflected from the liver function test. Ultrasound is good screening. Fibroscan is more objective, and also when you're putting them through optimization protocol, then reversal is you can monitor them through Fibroscan and cross-sectional imaging. And whenever biopsy, actually, there's no harm in biopsying and having more information than actually regretting later on. Okay. So when we come to volumetric assessment, there are lots of software nowadays available, and I won't go into details, but even 2D volumetry is also same. And if you don't have fancy software, you can still carry on with the 2D volume. It comes out to be same. There's not much of difference there, but it's good to have, if you have those software available, then actually you can plan the operation in a better way as well. Okay. So there are lots of formulas available for very preoperative volumetry, and what it just shows that nothing is certain. And as I said before, so when you're looking at, you need to look at the percentage, you need to look at the actual volume which is going to be there in the. Hi there, am I done? Am I done? Okay.
You proceed. Somebody is cross-talking. Request everybody to mute their mic. Dr. Vinendra, you can proceed.
Right.
Okay, so there are lots of formulas. So you can pick up any one, but the simple one is just to
It's not audible properly, I think.
यार काला वाला बैग नहीं लाई हो। ये काला वाला झुलवा,
क्या
काला वाला झुलवा जो था आपका।
प्यूमा वाला?
हाँ,
इतना कपड़ा लेके जाओगे क्या?
कहाँ है वो? उसमें 4 दिन का सामान तो ले जाना पड़ेगा ना।
टैगोर टाउन तो चलना ही पड़ेगा।
चुप रहो यार, चलना पड़ेगा। सूखी एक ठो आलू और एक ठो पटर डाल के खिलाती हैं और ऐसा लगता है कि बहुत बढ़िया भोजन है यार।
अब तो चलना पड़ेगा फैक्ट्री।
Same network error only.
about 17 centimeters. She had no clinically significant portal hypertension. You can see the large tumor there in the right lobe of the liver going into segment 4A as well. And her alpha fetoprotein was 200, platelets were 210. And this has just to show her scans. And this was the volumetries. So just to emphasize again on how the volumetries are done, whole liver volume was about 1700. Tumor volume was about 792. So FLR was about 246. So we did an extended right hepatectomy for her. And because this was mostly tumor which was coming out, there wasn't much of normal liver parenchyma coming out. And she made an uneventful recovery. This is just the specimen along right extended with choroid lobectomy, R0 resection. And this are post-operative scan. She did develop recurrence later on in the left lateral segment and required an RF ablation, but still alive 8 years post-resection. So when you're doing assessment, you also need to look at the functional assessment. And obviously, if there is ascites, then major liver resections are contraindicated. Ascites is controlled, then you look at the bilirubin. Bilirubin is normal or it is high. Then depending on bilirubin levels, again you can decide, because if it is more than 1.5, then it is about segmental resection. If it is more than 2, then you should not be resecting them. Then ICG is important. ICG, you need to look at the retention, and if it is ICG is more than 10, then again the major liver resection is not there. So if it is about normal, then you can do bi or trisectionectomies. It is 10 to 19, then it is 20. It is about left hepatectomies or monosegmentectomies. If it is 20 to 30, then it is about segmentectomy. It is more than 30, then limited resections. So this is an important part of evaluation actually. And so if ICG is available, it is good to do. Otherwise also you can do the assessment based on all other parameters which I have told you before. But ICG we do routinely and plan for any major liver resection, and then plan accordingly as well. Nowadays, a lot of functional imaging is also available, but it is not routinely available. If it is available, then you can use those as well. I think Zipmer has those functional imaging available, and they can be of help as well. Okay, can you hear me? Hello? Can you hear me?
Yes, we
Yes,
can
sir.
hear you.
Yes, sir.
Yeah.
Yes.
Okay. Yeah, just keep prompting.
Yes,
So
sir.
that, okay. Then coming to assessment for portal hypertension. So one of the things is, normal belief is if you have portal hypertension, liver resections are contraindicated. This is not how it works. So you need to look at other parameters in order to decide, because a lot of patients will have cirrhosis. Cirrhosis is not a contraindication. So you need to look at the CTP and MELD score. So CTP-A is always okay. Early CTP-B can still be planned for a liver resection depending on all other parameters, how the ICG is, where the location of the tumor is, and depending on those, and whether you're going to, in terms of whether you're going to leave any congested or ischemic segments, and depending on those, you can decide on that. So MELD is a very good. So if a MELD of 9, below 9 you can safely do resection if other parameters are fitting into, but if a MELD of more than 9, then you need to be careful. Then in order to look at clinically significant portal hypertension, there are various parameters assigned to splenomegaly, platelet counts of less than 100, or you've got varices. Then HPVG is now being used very commonly to assess portal hypertension when it is borderline. So if you got it HPVG of more than 10, then again a major resection actually it should be careful about. Now, one of the things with HPVG is that when you have large tumors, this may not be actually reflection of the right pressures. So you can just imagine in this, I'll just show you this. So if you have large tumor like this and you're trying to wedge into the hepatic pressure, you won't get the right reading. Even if you try to do on the left side as well, you won't get the right reading. So just be careful on, on a single reading of HPVG, you should not be actually deciding whether you want to do a resection or not. Okay. Now, coming to this point about clinically significant portal hypertension and major liver resection. So this is some of the data which shows that in a given case, actually you can achieve good survival in those situations as well. Okay. And on the propensity matching, there was no difference in terms of overall morbidity and mortality as well. And this is HCC data. And this again shows portal hypertension actually doesn't really contraindicate directly in terms of liver resections as well. Okay. And just coming back to this point of HPVG, this was an important study published in Journal of Hepatology, where 70 patients with a median MELD of 8 and 34 had an HPVG of more than 10. And out of those 17 patients actually who had more than 10 HPVG had an uneventful post-operative recovery. So just trying to make the point again that don't decide on single reading of HPVG whether you can do a major liver resection or not. Okay, so coming to optimization. So this is just some of the patient I will take you through. 71-year-old male with HCC segment in right lobe of the liver, segment 6, 7, and 8. ICG was 4, and upper GI endoscopy showed no varices. You can see a large tumor in the right lobe of the liver. Okay, so this is this was the volumetry. So the right lobe without MHV was 675, and so with the right hepatectomy, the remnant was about 34%, and the background liver doesn't look that bad, but he did had a bit of chronic hepatitis as well. So we did underwent a right hepatectomy. He made an uneventful recovery. This was unifocal moderately differentiated HCC, background liver was steatohepatitis. So again, just to make that point that because large portion was coming out was of with the tumor, so in spite of an steatohepatitis, he made an uneventful. So these are cases you don't need to think much. Just evaluate basic things. If you have ICG, do the ICG. Look for clinically significant portal hypertension, and if the volumes are safe, then you can go ahead and resect them. Okay. Then this is just intraoperative photographs of the same patients as well. And this is post-op follow-up scan. So what are the methods of increasing future liver remnant? So one is portal vein embolization. I'm sure you're aware of this, that you embolize the portal vein on one side and the liver will get hypertrophied on the other side. The concept have been now quite old as well, and this is one of the safest way to optimize the remnant. The other one is now, which has come, which is becoming more popular, is to add liver venous deprivation. Basically, you embolize the right hepatic vein as well, along with the portal vein, hypertrophy of the remnant as well, and that can. So one of the issues with portal vein embolization was inadequate hypertrophy. So if you embolize the vein along with it, then you can achieve better hypertrophy. And the third way to do is ALPS, that is associating liver partition with portal vein ligation. So this is a two-stage operation. In stage 1, you go and ligate the portal vein and partition the liver, and then in step 2, you take out the part of the liver with minimally invasive as well, and a lot of people are trying to do it laparoscopically or robotically as well. Okay, so just take you through few cases. So this is 72-year-old with cholangiocarcinoma type 3A. Maximum bilirubin was 30, and her total liver volume was 1400. She was planned to have an extended right hepatectomy. Left lateral segment was 265, that was 18%. So we did a left PTBD and left right portal vein embolization. There was a good hypertrophy of the left lateral segment, you can see there, and we did the section extended right hepatectomy with chordate and segmental main portal vein dissection as well with end-to-end anastomosis and MY. And this was perihilar adenocarcinoma, background liver bone stenosis, but there was increased portal and periportal fibrosis. He had a prolonged ICU stay, a hospital stay with ascites for 4 weeks, but finally went home as well. Okay, so this is just simple how portal vein embolizations are done and how patients. So the main controversy with portal vein embolization is what should be the optimal timing of resection after portal vein embolization, what you do in inadequate hypertrophy, and is the tumor growth accelerates after portal vein embolization. So in terms of optimal timing, most literature will say 3 weeks after the portal vein embolization. That's when most of the hypertrophy will happen, about 80% or so will happen. So if you reimage after 3 weeks, it will give you a good idea whether it is going to regenerate anymore or not. Okay, because a plateau is reached after 3 weeks actually. Okay, then there is something called kinetic growth rate, which you look at in terms of how much growth has happened over the days, and then you divide it on daily basis and see. So if you have a low kinetic growth rate, then the chances of morbidity and mortality increases. And this is also one of the ways to look at it, because patient who actually whose liver didn't grow after portal embolization, they're going to struggle and they are going to develop post-hepatectomy liver failure. So that's one way of looking at it after port. So it's in a way it is selecting out the patient. If the remnant doesn't grow, then those are patient actually they are not going to get benefit from your resection. They will have problems. Okay. Then inadequate hypertrophy. So I've already addressed this. If you have inadequate hypertrophy, then you can do two things. One is you can also embolize the segment 4 vein, which can actually lead to good hypertrophy as well. This you can plan beforehand, or if it has not happened in the first place, then you can do it in the second go. Or the second way is to do a right hepatic vein embolization, which can actually lead to good hypertrophy after the embolization. So there is a lot of literature now coming, case series about LVD, total liver venous deprivation on the ipsilateral sign, and there also debate about whether you should do it in a simultaneous way or you should do in a sequential way. So there's not that much data on clarity, but if somebody has got a very low FLR, like less than 15%, then it may be good to do it simultaneously, both hepatic vein and portal vein in one go rather than doing it sequentially. Okay, so this is radiological simultaneous portal hepatic embolization RAS procedure, which is being this one. So FLR, if it is less than 15, then it's it's better to do simultaneous. So growth acceleration after tumor growth acceleration after portal vein embolization, we did some of this work. It does happen, and other authors have also published that after portal vein embolization, increase arterial response, so there is an increased growth of the tumors. So whenever you're doing this, you should combine portal vein embolization in a given case either with chemotherapy, which will be in the cases of colorectal cancers. In HCC, it will be about TACE. So TACE, doing TACE before precision and combining it